these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
For insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold
these truths.
We hold these truths.
with Dan Crenshaw.
The Eagle has landed.
Welcome back, everybody. Greatest podcast ever. I am here, very honored to have Seema Verma with us. Seema, thank you so much for being on.
My pleasure. Thanks for inviting me on the best podcast ever.
It is the best. A lot of people say so. But that's not what we're here to talk about. We're here to talk about Medicaid mostly. We'll talk about some Medicare too, but I know your expertise is certainly in Medicaid, and it's a hot topic for a number of reasons. Let me tell the audience a little bit of your background and why you are so infinitely qualified to be speaking on this subject. You were the administrator of the Centers for Medicare and Medicaid Services, which is CMS, from 2017 to 2021. Longest tenure in modern history. I wonder why that. Could you just take the job longer? Like, what is everybody just burn out of that, or what goes on there?
Yeah, no, I don't know. I mean, for me, I just wanted to get a lot of stuff done, and so you need time to be able to do that. Most people are probably year and a half, 2 years is the average tenure.
Yeah, and you oversaw a budget of $1.3 trillion, which is a third of the federal budget, health insurance programs for over 140 million Americans and managed over 6,000 employees. It's a pretty intense job. Mm-hmm. So you see those kind of numbers, maybe it's not so crazy that there's high turnover. Before that, you were the architect of the Healthy Indiana Plan, served as healthcare administrator under both Governor Mitch Daniels and Governor Mike Pence in Indiana. So we're going to get into some details, I think, on Medicaid policy, but look, not everybody listening to the podcast has some wonky policy background in CMS. Myself included. I'm learning, but we need to start from the beginning. What the heck is Medicaid, and why is it designed the way it is? How did it originate? What was the intent of it? When did it originate? How is it different from how other countries approach it, and what are some of the variations between states? So maybe let's just start with real broad strokes.
Sure. So basic programming, everybody's probably heard more about the Medicare program, right? Which serves elderly people over 65. Well, the same time that Medicare was created, Medicaid was also a new program at that time. And the idea was to take care of what I would say the medically needy, the aged, blind, disabled population. So the poor, aged, blind, and disabled population. So as you can imagine, folks that are paraplegics or severely disabled, Medicaid is the payer that usually steps in for those individuals. Over time, we've seen the Medicaid program grow and grow. It has now grown to pregnant women. Also through the CHIP program, it's children's health insurance. And then with the Affordable Care Act, it's now also taking care of adults as well. It is a joint federal state program. So whereas the Medicare program is run entirely by the federal government, this is a joint program. And depending on the wealth of a state, they're contributing funds towards their population or their Medicaid program. So in some states, it may be 30, 40%, and in some cases, it's as high as 50%. And that's a really important point because it's jointly funded by the state and federal government, where the federal government is matching what the state puts into it. And so you have a joint management of the program. Because of its structure, this is a real important point. You put in $1, you get $3. So over time, you can imagine states sort of looked at this as, wow, this is an opportunity to bring revenue into our state. And it's grown. It is now the number 1 or number 2 budget item in every state. So it's a massive program. It's become really expensive. And as it's grown, you've seen the federal government respond to that by having more and more oversight of the program.
Yeah, that's for sure. So every state manages its own program within some parameters set by federal law.
Correct.
And you guys, the regulatory body and CMS. And it's grown to the number 1, number 2 budget in America. Fundamentally what it is, though, it's a reimbursement program. It is reimbursing. So a patient or a person, because so it used to be a patient, and it's important to distinguish between these two terms. It used to be a disabled person. That's how the program was intended. It has become, because it's easy for politicians to promise more things. So, well, what if we get kids on it? What if we put our impoverished population on it? We have this program where we're giving things away, so let's just add more people to it. And turns out they'll be our voters afterwards. Anyway, that's the cynical side of me thinking politically, but that's how it's evolved over time. And so it's evolved from being for disabled patients to just being persons on it. And it's a reimbursement. So a person is enrolled in the program, and then they get a network of doctors associated with that who actually will take Medicaid dollars. Not all doctors do, because it does reimburse less than what they would otherwise get from insurance. So that's a problem we might dive into here. Or it's a problem. I don't know if it's a problem. It's a fact. It is a fact we must deal with. And then Medicaid agrees to reimburse for those services. Now that's a sort of government reimbursement model, fee-for-service model. How do other countries do this? A lot of people talk about the Medicare for All group looks to Canada and the UK as their sort of favorite. The UK is more like a giant VA. Canada is more like a Medicare for All. Maybe you agree or disagree with that. And then a lot of European countries have a lot of mixes of all of these healthcare plans. I just maybe talk us through, how we ended up with that situation. Is it the most optimal? How does it compare to other countries? What can we learn from other countries, and and then let's talk about modernizing our own system.
Sure. So, if you think about it, to some degree, we have a single payer at two ends of the spectrum. Over 65, right? The government's paying your bills. And for very low income and vulnerable populations, the government's paying your bills. And I think that's an important point, right? It's kind of a health financing organization, right? As opposed to somebody that's really thinking about outcomes. What I think Medicaid has lacked is accountability in the program, right? States can just spend, right? There's no accountability in terms of the quality or the outcomes. Are we actually improving somebody's health? Are we actually making a difference? Or are we just sort of paying the bills without any expectation of outcomes? And I think, the points that you made are spot on, which is that Medicaid has become, it's a pretty cheap program. And the reason why it's inexpensive is that they don't pay the doctors very well or the providers inside the program. It's usually considered the lowest payer. So you have a lot of providers out there that say, we can't afford to see a Medicaid patient. It doesn't really meet our cost model. So then all of those people that are on the program, they have access issues. And so we know, some data has been out there that says 30% of doctors won't even take a Medicaid patient. And so that becomes problematic for those individuals because where do they go? Access is limited. And I think that's a really important point as we are talking about putting more people on this program. To some degree, you're really hurting the disabled people and the people that it was intended for, because now there's, fewer doctors for people to see. And so I think one of the things that we haven't quite built into the Medicaid program is the quality and the accountability. You've seen some states trying to build that in at the provider level. There, a lot of states are now contracting with private organizations and things like that to run the program, to build more accountability. But I think at the end of the day, taxpayers have to say, what value are we getting out of the Medicaid program, right? We're spending all this money. It's crowding out funding for schools and infrastructure and all these other things. We're spending this money. What are our citizens getting? Is their health being improved? Do they have access to care? Is it good quality care? I think that's one of the structural changes that should happen in the Medicaid program.
So, I think Democrats would just say, well, why don't we just make reimbursement payments higher and then solve that problem that way? Of course, that's something that might happen with Medicare because it's entirely funded by the federal government, but because it's a mix of state and federal, and states do have to actually think about a budget in the way that the federal government should, but does not. Is that what prevents it from spiraling from those reimbursement prices spiraling up?
The states control the rates and they can pay what they can afford to pay. And so a lot of them, which you'll see when state budgets, and as you know, they fluctuate. There's good times and bad times, but during bad times, a lot of states will say, we want to cut the Medicaid reimbursement rates. And so that's usually their lever. And there's not always, not saying all the time, there's not always a lot of creativity about how do we increase quality? How do we reduce costs?
Yeah. And when you're adding more people, and when people say expand Medicaid, what they mean is they're just adding more people to the population that's enrolled in the program. And so an already finite number of doctors who will take Medicaid becomes even harder for those patients to access those doctors.
Right. And let me give you another example. And this really played out with COVID. So what most people don't know is that, we talked about Medicaid's coverage of the aged, blind, disabled, but the disabled and aged population, many of them are served in nursing homes or long-term care facilities. Medicaid is actually the number one payer in nursing homes and long-term care facilities. And we saw how difficult it was for nursing homes during COVID. Many people died, unfortunately. And it really brought the issue of quality in nursing homes, right? And a lot of that came back to what you hear from nursing homes is they're operating on these razor thin margins, especially those that are serving large numbers of Medicaid populations. They can't afford to attract the type of workforce that you need to be able to ensure that you're adhering to all those infection control practices. And so that lack of investment by Medicaid into reimbursement for nursing homes, I think, had a big impact on what happened with COVID.
So yeah, and it's easy to say, well, we should increase reimbursement, but that because of the cost sharing with states, that would have to come with a raising of revenue from the state level too.
Right. And states are all right. I think it's important to say it is the number one, number two budget item. So you're competing against education and infrastructure and safety and all those different things for a state. I mean, they're struggling to pay for it. What I think is also really important is the economic outlook for Medicaid is very concerning because you have the baby boomers that are aging and they're going into nursing homes, and nursing homes are the most expensive line item you have. And so the projections by 2030, 2050 is that the expenditures for Medicaid could actually double by that point. If you look at the Medicaid actuaries report, this program is only going to get more expensive.
And so one of the arguments for expanding Medicaid is that you get people access to care that they otherwise wouldn't have. Maybe they don't get it through their employer. So we're talking about the individual market here. And as a result, they get preventative medicine, they get more access, and so don't have long-term health issues. So we save money in the long run. Does it really play out that way? Or is it a mix?
I don't think that we have long-term studies, right? That being said, I mean, clearly, if you're sick, you have a health issue, having healthcare is going to be better for you to be able to have that access to preventative care. If you have a chronic disease, I mean, if you're sick, definitely having medical care is better for you, and having access and being able to choose providers that are going to give you high quality care is important. I think the issue with Medicaid and Medicaid expansion is that, from where I sit, there's value to people having health care. My question is Medicaid really the best way to take care of these individuals? Is it the best program? Medicaid was built for the aged, blind, and disabled. A lot of the policies are geared towards them in terms of cost sharing. We can't maybe expect a quadriplegic who's not working to make a contribution towards their health care. They don't have those resources. Somebody who is an able-bodied individual, maybe they are working. It should be a different set of programmatic rules. It's two different populations, and I don't think that Medicaid was necessarily designed for that population. I think that's
and I think this creates some societal resentment too. The idea that you work hard for your job, you work hard for your private health insurance, then you see somebody who's able-bodied but can use Medicaid when that was intended for the disabled. And again, it doesn't mean we're not looking for ways to provide access to care for the impoverished, let's call it the able-bodied poor, because I think there's some societal value in doing so. The question is how we do it. And And so, okay, so then let's talk about that a little bit and modernizing it. Talk to us about the discussions and what these, and let's define the terms of value-based care versus fee-for-service, and what the current situation is with Medicare and Medicaid, and how maybe we would like to see it if you had all the power in the world and you could wave magic wands.
Well, and you bring up a good point, because I do think there's societal value to ensuring that people have access to healthcare, right? And we've all heard some of the horror stories of people that are uninsured. But if we look at the underlying issue is affordability. That's why people don't have healthcare, because they can't afford it. And so when I always get concerned about when I hear about proposals that say, well, let's just expand Medicaid or expand coverage, because all we're saying is let's throw some government money at the problem. And as you know, okay, you'll solve that problem for those people, but if healthcare is just getting more and more expensive, you're just moving the problem. More and more people are going to have to go on to government run healthcare because the costs are still high. And if you're not able to lower them, ultimately, more and more people aren't going to be able to afford it. So I think it's very important that we focus on how do we lower the cost of care. And that was something when I was with the administration, the Trump administration, that's what our focus was. Because to me, if we start solving some of the underlying problems in our healthcare system and what's driving up the costs, then we're going to actually improve accessibility and affordability. You asked about value-based care, which I think is a really important part of a solution going forward. Right now, the way most payers, most providers are paid is what we call the fee-for-service system, right? So you go in, you your labs, and you see the doctor, you get an x-ray or surgery, and everything's paid by everything that you do. So, you can kind of think about it. There's a perverse incentive, right? Because the sicker you are and the more services you need, the more the healthcare system, the more money that a hospital is going to make. So there's an economic incentive to do more. In a value-based system, we say, let's turn that around and let's pay you to keep me healthy and to keep me out of the hospital. And so instead of just paying you for everything that you do, we're going to assess the relative risk of the patient and give you, essentially a budget or amount of money to manage. So, now you can see some investments, and hey, it may make sense for us to send a nurse out to your home. Or, for example, COVID's a great example. CMS just moved to say, for some people that haven't gotten vaccinated, we'll actually send somebody out to your home and give you your shot, because, it may actually be over the long term more cost effective to do that than to have you hospitalized for COVID. So it actually has the provider thinking about, what innovative things can I do to keep this patient healthy? So if you're paying somebody a fixed amount, they may say, John over there is homeless, and we need to figure out how to get him into a home, because that's actually contributing to why he's always showing up in the emergency room 3 times in a week. And so it really has providers look at the whole person and think about, how do we keep this person healthy? They're now incentivized to lower costs. And it's not just about cost. They are actually paid for better outcomes. So if they can show better quality, they're paid for that. So, I think this is something that's been a bipartisan issue. It's been the Obama administration, the Trump administration, even the Bush administration. People have been working on this concept and trying to implement it where we pay providers differently. I think that has a real promise of better quality, better outcomes, and lower costs for the country.
We've been working on it for a long time, but we're not there yet. Is the private insurance industry closer to that? Do they talk the same conversations?
They've been doing a lot of it. In my view, it's probably not moving fast enough. Medicare is very influential in the space. They've been working on it. I think as a country, we need to accelerate it, because a lot of providers don't want to do it. A lot of it's voluntary. And so, quite frankly, for providers, it may be more comfortable, maybe easier to be in a fee-for-service system. And so I think unless we start pushing at it with our public programs as well as our private programs, we're not going to see the type of momentum we really need. Because if you think about it, in terms of controlling costs in this country, we're not going to ration care, right? You don't want to say, well, we're not going to provide this, we're not going to provide that, like a lot of socialized countries that have socialized medicine, that's sort of their response, right? We're going to ration care. You don't get to have, this surgery or this treatment. So these are alternatives to that type of approach to lowering costs.
Yeah, and it's important to note that in the fee-for-service system, it does create a situation where, you can say that you have access to a doctor, but that doctor can only see so many patients.
Right.
And they have to if they have to choose between a Medicaid patient and a full price paying patient, they're going to have to choose that full price paying patient just for their own. And you can call them a bad person all you want. It doesn't change the fact that they have expenses too. And, the alternative may very well be that doctor just doesn't go into practice at all. Right. And then you have even less doctors. What COVID brought I thought was interesting about COVID statistics was when we were all freaking out about ICU beds around the world. How many ICU beds do we have per capita? Like everybody knows that statistic now. And we have a lot more is the answer. We have way more per capita than all of these other developed countries, UK, Canada. And that's because we just, we pay a lot more, but we also have a lot more. Doesn't make it perfect. But getting, making it more perfect would be, for instance, going to this value-based system. I want to talk more about that and then how that relates to direct primary care. But let's talk a sticky subject in Texas, the Texas Medicaid expansion. This is a hard one to unpack. You'd probably be really well suited to help us unpack it. Help the audience understand what Texas does differently with Medicaid. We are not an expansion state. And so Democrats just say, well, you're just leaving money on the table because Obamacare said that they would reimburse 90%. And we're like, well, it's still 10%. That's still a big chunk of change. But, that's a hard argument to debate because it does feel like free money. Now, of course, it's not, but that's a bigger subject about federal debt. And they say it's just money left on the table. Texas does it a little bit differently, though, through 1115 waivers. Could you help us understand what exactly that means?
Sure. So a couple of things. The term waiver just means, like we said, I think you sort of referenced that the federal government has these rules. And if you want to do something different outside the rules, you come and ask for a waiver. Waivers are very common. Pretty much every state in the country has some type of a waiver. In Texas, Texas used to run the Medicaid program a long time ago. And then they went to managed care where they actually contract with private entities to run the program. And that move actually created a lot of savings. And so Texas sort of said to the federal government, well, we still want to keep that money in our system. We're providing, better care, lower cost, quality. We want to be able to keep those dollars in the system. And so they created what we call uncompensated care pools. So these aren't necessarily people that are, on the Medicaid program, but we know because Texas is a border state, right? They have a lot of undocumented individuals coming in. People come into the emergency room, and hospitals by law have to treat whoever comes into the emergency room. So I think it's important to note Texas has some very unique circumstances, and those individuals may or may not be on Medicaid. So they had a lot of uncompensated care. So Texas said to the federal government, can we use the savings that we are, gleaning through these managed care programs, and can we create uncompensated care pools for our hospitals? And we can, pay them because they're seeing uninsured individuals and Medicaid's also not a great payer. So can we also provide some additional funding to them? So that was sort of the deal that Texas has had. And because of that, it's possible that Texas has said, we're not interested in Medicaid expansion because we have these uncompensated care pools that are helping to pay for our uninsured. When it comes to Medicaid expansion, I'll be the first one to say, to me, it's a state decision. Every state has to assess their situation, what they think is going to work best. And part of that assessment is the finances of it, right? With the uncompensated care pools, it's a fixed amount. Texas knows exactly how much money they need to put into the program to draw down those federal dollars. In a Medicaid expansion, it's kind of a one-for-one. Whoever signs up, you have to pay for it, right? It's a open-ended entitlement, right? So if 100 people show up, you got to pay for that. If it's 1,000 people that show up, you have to pay for that. When you also do a Medicaid expansion, you're also paying for emergency services only for the undocumented as well. So it's a big financial consideration for states. How are they going to pay for it? And how are they going to pay for it over the long term? Because by having it, you may actually increase the volume or encourage, some more spending in this area. So that's why I think it's a tricky issue. And Texas is different from other states because they have had these uncompensated care pools.
Yeah, that's interesting. And is that, are you familiar with Harris Health and how it works here? And that's sort of our low income healthcare system at the county level. There's LVJ Hospital. It's primarily for low income. I don't know if you know much about that program, and if you want to describe how the Medicaid dollars sort of fit into that.
Yeah, I think that's part of the uncompensated care pools. My guess is that's how they're getting funded, right? Mm-hmm. The money is flowing through the uncompensated care pools to the county level to be distributed.
Yeah, and I think that's right. It allows these hospitals to stay afloat, to maintain quality of care, because they're seeing Medicaid patients for sure, but they're also getting that additional money, and that's different than 340B program.
Right. The 340B program is a drug program. It's basically giving for those institutions that are taking care of a lot of low-income Medicaid uninsured individuals. The federal government gives them discounts for the medications that they provide. So, for a safety net provider, they're taking money from a lot of different areas. Some of it comes from the uncompensated care pool, drug discounts, Medicaid. So their funding comes from a lot of different places.
Okay, so back to value-based care. And I'm a big fan of trying to transition us to a system where the patient is empowered with these dollars. Mm-hmm. I always point out that, look, let's agree that people need health care the same way that we agree that people need food. And but what we don't do is say, hey, go grocery shopping and then go to the checkout counter and some third party will bill the grocery store, be billed by the grocery store for whatever you take out. That would be a weird way for us to deliver food. Instead, we give people basically a voucher in the form of a food stamp. Now, food is obviously far less complicated than healthcare, but the incentive structure could be the same, empowering the patient with dollars, and looking at ways to have the money follow the person, similar to past programs with disabled people, and looking at ways to. We're looking at ways legislatively to transfer that over to primary care. Mm-hmm. I think everything hinges on primary care. When people talk about, we don't know who our doctors are, everything's so confusing, it's because America has basically lost their relationship with the primary care doctor. And a lot of people just don't even know who it is. Like, if I'm sick, do I call a doctor? Do I call my insurance company? Like, how does this even work? It's a very confusing system, because you got to make sure the insurance is approved and all this. So direct primary care is something I tend to like a lot. It works pretty well in the Houston area. It's expanding quite a bit. And it's essentially a subscription, just for the audience. You know what it is. It's a subscription based model where you have a doctor, you pay that doctor on average about $75 a month. So we're talking a cell phone bill, we're talking a gym membership. And that's total access for primary care, a lot of lab work. There's things included in that. It's not necessarily insurance, and it needs to be distinguished from that for breaking your leg or getting into a bad car accident. I mean, different treatments are not held under primary care. But is there a way, or do you foresee a future where we eventually start transitioning those dollars to the people so they can choose? And then it's not just because I philosophically like the idea of choice, it's because that's how you make the market work better and keep costs down, and while also keeping quality up. There's a reason for it. It's not just ideological.
Yeah, I think that I agree with you. I think direct primary care is a great model, and it's actually very consistent with value-based care, right? So if you think about, actually during my tenure at CMS, we created new models where we would pay primary care doctors and just take what we call total risk, total cost of care. And so it's the primary care practitioner that's sort of in charge. They're coordinating your care, and we gave them incentives to try to lower that total cost of care. They obviously had to meet, these objectives around quality. So I think these models where we're paying more to the primary care doctor is really important and very promising. What's interesting in the private model, in the private market with direct primary care, which I think is fascinating, and I love this part of them, is they also have built in a lot of price transparency, right? So you may come in for a subscription, your general subscription, but then they'll say, if you need lab services or you need this is what the cost is. And I love that model, right? Because you're picking, but you also, the consumer is cost conscious because they can see what everything is going to cost. That's why, we worked so hard on price transparency with the Trump administration and really pushed in some landmark regulations, because I do think that patients have to be a part of lowering cost and improving quality. It's bringing those market-based principles where people are choosing providers based on cost and quality. I think that concept of direct primary care, absolutely, people should be thinking about that for Medicaid, right? I mean, why not give a capitated payment to a primary care provider and do that through Medicaid? There are some models out there. I think I want to say maybe North Carolina, they've done some of this and they've actually had great results because they develop that relationship with the patient. They understand some of the other social determinants, like we talked about, whether it's housing or food or some of those other issues, where the doctor's relationship with the patient is deeper. They have a better understanding and a better way of managing the patient's care.
Yeah, and is there a vision that we can get to? I think Republicans have to offer a vision for healthcare,
right?
And then don't use scary terminology like repeal and replace, because that makes people think,
right.
It sounds like a bat to the system, because maybe it was. I think we need to provide a vision that's simple and easy for people to understand, and then an honest 10-year glide path to that system,
right?
Legislatively speaking. And again, I'm just kind of bouncing ideas off you here, but I think that vision should be empowering the patient with those dollars through an HSA account. I'm oversimplifying things drastically, of course. Empowering patients who cannot pay for it otherwise through an HSA account, means tested, and allow that patient to buy into a direct primary care provider of their choice. Go on that app, go on an app and put in your zip code and you can choose. And then that primary care provider is your quarterback. And the need for a quarterback cannot be overstated. That doctor helps you then choose your insurance. What's the right insurance plan for you? And then the third thing would be to, how do we talk about the really catastrophic care? I mean, I think like 85% of America's health costs are for chronic illnesses, chronic care, the nursing home costs that you talked about. I guess that would be all kind of falls into the same category, because age, I suppose, is a chronic condition. It's not going away. So, the reinsurance models, uncompensated care models at the state level seem to be a good model to deal with those costs, and also which keeps premiums down on the private insurance side. Now, that's complicated, but I don't know that it's easier to. I don't think you can simplify it much more without being dishonest.
No, and I think those are some reasonable and great proposals. And I think there was sort of a messaging or communications issue during the debate about healthcare in 2017, right?
A little bit. That's maybe an understatement.
It's a little bit, but it's like it's like, we're not against healthcare. We're not trying to take people's healthcare away, right? I mean, but
we just hate it. We just hate all this healthcare.
We didn't like the structure of Obamacare, right? And we said, yeah, it's taking care of these people, but it's actually increased the price. Prices have gone up 100, 200% in some areas of the country. So you've helped these people, but now you've made healthcare worse for these folks over here. So, to me, I think this country has to solve the cost crisis in healthcare. One of the things that I think is really important is putting patients and doctors in charge. That's important in terms of decision making. The other piece of it is we have to bring back the free market to healthcare. The free market or market-based principles for every other sector has brought down costs and improved quality. That, to me, can happen in healthcare, but we have to be able to make some of the changes to have that happen. First off is price transparency. if people can't shop around for healthcare when they don't know what things are going to cost, they don't know what the quality is. The second thing is we have to make sure that there is fair competition in our country around healthcare services. Medicare pays more to hospitals than it does to a surgery center for the exact same procedure. And some of that's warranted because hospitals have a higher level of acuity in terms of the patients that they serve, and they have more regulatory requirements. But, if you think about a doctor's visit, if you're in a hospital outpatient visit, Medicare will pay more to the doctor because they're in the hospital outpatient versus just a normal doctor's office. And what we've seen is the formation of a lot of monopolies across the healthcare system where hospitals are buying up physician practices. Those are the kinds of things that are contributing to increasing our cost of healthcare. Look at drug pricing. We've seen, the issue in drug pricing is the Part D program in Medicare works really well. Premiums have gone down every year, at least the time that I was there. But in the Part B program, the government saying we're paying for the cost of drug plus a percentage. So there's an incentive for drug prices to go up. So, I think it's a broad-based look at the policies that we have, especially in the Medicare program, that are decreasing competition. So we need to empower patients with information, cost, and quality so they can make better decisions. And we need to create a framework of competition in the marketplace so that providers are delivering, as you said, value-based care, better care, lower costs, and patients are empowered to make decisions based on those two factors.
And maybe we'll continue down this thread because we haven't really talked about Medicare, but if we're talking about drivers of the debt, Medicare is number one by far and away.
And Medicaid, Medicare together.
Yeah, healthcare costs in general are primarily what's driving our debt. Social Security, obviously a problem too, but it's not a runaway problem. Also, it's mathematically much easier to solve if we just make some mildly hard decisions. Much harder to solve the healthcare problem because you do have to fix the price problem first. And there's and I think what the left misses in this debate is you can fix the price problem by price setting, which other more socialized medicine countries do. Sure, you could, but then you'll have no more things. Things in this case meaning new drugs, more doctors, more hospitals, new innovation, new medical devices. Because what would be the incentive to even make those things? And they might flail and say, well, the government will make it. And it's like, no, it won't. Just stop. It won't happen. Yes, NIH does provide a lot of funding, but people don't realize that funding is for basic research. And then that basic research takes billions of dollars to commercialize. And so, a lot of things swept under the rug in the nice sounding Medicare for All debates. Medicare for All is fundamentally just price setting. Like that's how we control costs.
Medicare's it's a price setter. That's what they do instead of letting doctors compete on the basis of cost and quality, right? That's the way it lacks.
And I don't know where I'm going with this ramble, but I'm trying to set a stage here for people listening, and then ask you, okay, given this runaway costs that are occurring, even with the price setting, because the price setting is still, like you said, it is still a percentage. So that incentive is in there to keep hiking up prices. How do we modernize Medicare? Is it the same discussion of value-based care that we're having with Medicaid?
That's exactly what I think. The way Medicare does price setting, and as the administrator, I was there for almost 4 years, and every year we put out a set of rules that say, this is how much we're going to pay for these services. And when I would get the memo, it would say non-decisional, because Congress has actually built in increases into these programs every year. So it's like every year we're going to increase what doctors are getting or hospitals getting. So it's like you have this fee structure and then it's built in these increases instead of letting the market dictate what the costs are going to be. This is why I think it's important, again, to go to value-based care, right? Because if you go to value-based care, we are now paying doctors based on what they produce or their cost and quality. If you're going to go pick a doctor, don't you want to know who does the best job at what price? That's how we make decisions about everything else in our lives. Don't we want to be able to do that in healthcare? And I think if you move to that system where, a doctor can say, okay, well, I can do open heart surgery, and it's not going to work in every case, right? If you're in an emergency, that's not going to work. But, for a lot of healthcare isn't just delivered in the emergency room. So it could be, if you have diabetes or some heart disease, and the doctor can say, I'm going to manage your care. This is the cost, and these are the outcomes that I produce. That, I think, actually puts, it's bringing market-based principles to healthcare. Then doctors are competing on price and they're competing on quality.
Makes sense. I was yelling at my dogs, but I muted myself, so we didn't have to cut
No
anything.
worries. It could have been.
Joe Biden wants to, he's not a Medicare for all guy, but he says, why don't we, but a lot of Democrats who don't go full Medicare for all say, but we should expand Medicare for all by changing the age from, 65 down to 55 or 50. I mean, there's really no limiting principle to what they're saying. And look, cynically, I think it's just forever. They just want to keep going. But what would that do? I mean, if today you said it's 55, what challenges do we face?
Well, a couple of things. The first most important thing I think for every American to recognize is we can barely afford the public programs that we have today, right? We just had a good discussion about Medicaid, number one, number two budget item. In Medicare, you have the Medicare trustees that look at the finances of the program. We all pay taxes throughout our lives to pay for Medicare, as you know, and they look at the numbers and they're warning us a couple of years in a row, Medicare will be insolvent by, it's changed the date. It's gotten closer and closer. I think the new date's 25, 26. That's right around the corner. So, Medicare's a great program. It does a good job of serving the people that are on the program. There's definitely some issues with it. But my first question is to people that say that is, who is going to pay for it? How are we going to pay for this as a country? We cannot afford, we're barely affording the program that we have right now. So that's why I think it's important that we have to solve the underlying issues in healthcare. What is driving up the costs? If you start to solve that, healthcare becomes more affordable, and then people don't need the government to step in and pay for their care because it's more affordable. So I think those solutions are, they're half-baked because all they're saying is let's throw more government money at the program. Let's pay for these people's healthcare, but it's not solving the problem of why healthcare in America is so expensive.
It's a very dishonest offering of services with the implication that there's no trade-offs, which is just a classical populist political tool. And I think generally, I think the right is flirting with populism in a bad way, but the left has always done populism. Mm-hmm. And that's what it is. What does it mean? It's just, hey, I'm going to tell you what you're feeling, which is that somebody's hiding these nice things from you. And if only they weren't so corrupt, we could just give it to you. And that's sort of the implication with this. Hey, what we could do is just make the age different. I mean, come on, guys. As if there's no trade-offs. There's always trade-offs. So, okay, affordability would be one. Would you see a similar problem that you've seen with Medicaid, which is you continue to expand the population, it makes access more difficult?
I think the other thing, and like I said, I was at Medicare the longest. One of the things I think it's really important to note with the Medicare program, it's a government program. And I'll give you, when the government's running things take longer, innovation takes longer. A great example of this is telehealth, right? At this point, we've all heard about how important and valuable telehealth was during the pandemic. And I think people appreciate that it could have a role to play in healthcare, people in rural areas, mental health services. So telehealth wasn't new, right? It was always out there. But guess what? The Medicare program didn't pay for it. They only paid for it in rural areas just for a few services. And that's a great example of the limitations of a government program. Now, from where I sat, I could see that it was a great idea, but as the administrator, the law did not permit me to provide telehealth services. That's the limitation of a government program. It means that everybody's weighing in, Congress is weighing in, the public is weighing in. Innovation for people that are going to be served by Medicare is thwarted. So you put more and more people in a government program, you're talking about delays, innovation, technology, new cures and treatments. If you think about, the private sector innovation that we've had, or the innovation that we've had in healthcare, it has come from the private sector. The more people that you are putting onto Medicare, I feel like we're gonna have a dwindling of that type of innovation that we see in healthcare that has come from the private sector. And I think people should understand that when you're on a government program, things take longer. Your access to new technology. You always hear people complain about, a great example is like a colonoscopy. If they find something during your colonoscopy and they treat you, that's not covered by Medicare. All these like little idiosyncrasies that cannot be fixed because they require an act of Congress, or they require the agency to go through rulemaking process. So you're talking about your healthcare becoming super bureaucratic. And I think that's a risk. Medicare, the innovations and the great things that we've seen in Medicare, they didn't start with Medicare. They actually they started in the private sector, and then they came to Medicare. We in Medicare look to the private market to bring innovation. You start putting more and more people on the Medicare program, you are bringing innovation in healthcare. You're slowing it down and you are delaying people's access. So that's another, concern that I have. You have the government making decisions about your healthcare rather than the individual.
And you get that rationing that some of these horror stories you see from the UK when somebody's refused care that wouldn't happen here.
And there are some things, like I'll give you some examples of, there's some new tools coming out where, you're able to use some really cool apps with your healthcare technology. Well, we can see that these things have real value to the patient, but the law doesn't allow us to provide coverage in Medicare because the law can't keep up with the pace of innovation in our country.
Yeah, and that gets to a frustrating permitting process, because for all the innovation that happens here, what we often see is it has to be outsourced in a way. It has the experimentation, the development has to happen outside the U.S. because our laws cannot keep up with the innovation. And so while we do have access to a lot more cutting edge drugs and cutting edge biomedical devices, it does seem to me that we could do better. That FDA approvals are unnecessarily ridiculous. I know you weren't in charge of the FDA, but it does seem to me that the point of the FDA was to approve safety. And when did it change from approving safety to also assessing whether or not a drug or a device is effective in the way that, according to the standard that we set? Stem cells are a really good example of this, where it's, stem cells can be used for a whole number of things. It's a pretty simple and cheap way to do things. But it's really still hampered by the FDA approval process, which sees it as a drug instead of what it is, which is your own body's cells being re-injected into you. So this thing we get in the way of ourselves sometimes, but whose fault is that? It's the government's fault.
Well, and you bring up an interesting point. People sort of focus on FDA and, this is taking a long time. After they get approved by the FDA, the drugs are available in the Medicare program, but a lot of
then you actually have to agree to pay for it.
And we have to agree to pay for it. So you can imagine how long, and sometimes in the Medicare program, it can take years for something that's been approved by the FDA to be available to Medicare patients. So, it may be available in the private market. Great example of this was some of these CGM, continuous glucose monitors. People had access to it when they had their private health insurance. But then when they got to Medicare, they had to give that up. It wasn't actually covered in the Medicare program because Medicare hadn't really kept pace. So I think that's another point with, the government running a lot of our healthcare. If everybody's on a government program, nobody would have had access to those, glucose monitors that were available in the private market. So it's just, I think that's something, that people should keep in mind when we talk about putting more and more people on government programs. That's also, a risk in terms of access to innovative treatments and therapies.
Yeah. Whether it's our VA system, which is entirely government run,
right,
or our Medicare system, Medicaid system, these live off the backs of private innovators and private healthcare. They
Right.
have
I mean,
to.
that's where you're getting the innovation from. You know, in Medicaid, a lot of the states have gone and said, we want a private healthcare company to run our program because they're going to actually do it in a more efficient way. Medicare Advantage is an example of that, right? We see great results with Medicare Advantage where the Medicare program is run by private companies and they compete, you know, side by side with the traditional program. And what we're seeing is this big increase where more and more people that are on Medicare, they're choosing to get their health care through Medicare Advantage, which are private health plans versus having the government run their care.
Maybe we can end with that because the listeners' ears are hurting with all this wonky talk of Medicare
Yeah,
and
it's
Medicaid.
very wonky. I'm going to apologize for that. I'm trying to keep it.
No, it's
yeah.
good. I think if people who are looking to understand the subject better, this is a great episode. But I was going to ask for a layman's explanation of Medicare Advantage.
Mm-hmm. Sure. So Medicare Advantage these are private health plans, Humana, United, and they basically say, you know, we'll get, you know, a kind of a premium, like, which is what you pay and for health insurance, and we'll manage your care. So essentially your healthcare is being run by a private company versus the government running your healthcare program. The other thing is Medicare Advantage, you know, we talked a lot about value-based care.
Yeah.
So Medicare Advantage is value-based care. They have a premium and they have to manage your care. And that's why you're seeing Medicare Advantage plans making investments in keeping people healthy. You know, we made a lot of changes to Medicare. We said, hey, you know what, if you want to provide home-based care or put a ramp in somebody's home, you know, give them meal service after surgery, you can do that Medicare Advantage because we're giving them a fixed sum of money and then they have to manage the patient's care. And we're seeing just a huge soar in the number of people going to Medicare Advantage. And during President Trump's administration, we saw Medicare Advantage premiums go down by 34%. You know, we changed the regulations, and in some areas of the country, those decreases were 50 and 60%. And premiums going down.
Explain the premium structure to me a little bit, because it's kind of similar to what I was talking about before when I laid out sort of 3 steps to envisioning healthcare differently: direct primary care, through direct, and everything through an HSA, but direct primary care, a premium support model for insurance, and then a reinsurance model for your more catastrophic cases that are just in the millions of dollars that you don't want to put on the rest of the risk pool. Medicare Advantage is kind of step 2, isn't it? So who sees does the Medicare patient see the premium, or does only the government know what the premium is? How do these plans compete?
Yeah, these plans are competing on the basis of premium, right? So it's just like in the private market where you're making decisions about how much do I want to pay out of pocket versus how much I want to pay in premium. Every year we have open enrollment, and, you know, plans put up there, you know, here's what we're offering, here's what your out-of-pocket expenses are, and here's the premium. So every year there's competition.
So but the patient is the one seeing those differences in costs and choosing.
And then they're making their decision. Obviously, we're contributing, that the federal government, we're helping pay for the premium, but the patient is also making a contribution as well. So, and I love that model because it's very consistent. You talked about direct primary care, right? Where you're paying a fixed amount. It's the same thing in Medicare Advantage. You're paying a fixed amount, you're getting all your health care. And these plans are competing for our seniors based on cost and quality.
Okay, how is that different from the ACA and how that structure is set up? So why did the ACA cause premiums to skyrocket so much, even though Medicare Advantage causes them to decrease? Because in Obamacare, you are still subsidizing plans
right.
in a marketplace. Let's put that in quotation marks.
So in the Affordable Care Act, that's the individual market, right? So not the employer. You know, you get a lot of people get their health care to an employer, and a lot of people go buy their health insurance on their own. So the Affordable Care Act really focused on that individual market. And in a lot of states, like I can tell you, I'm from Indiana, and the way that they structured their market is they took out the high risk people, they put them in a high risk pool, and the government subsidize it. With the Affordable Care Act, they put everybody together, the high risk people and the low risk people. And that's why premiums went up in lots of areas of the country. And so in terms of why the premiums went up, it's that mixing. In the Medicare Advantage program, that's like a group of people where we already knew what their health care costs were, and you've got the high risk people and the low risk people. So in that case, it's sort of already accounted for. But in the Obamacare market, it mixed those two groups together, which is why you had that increase.
Yeah, that's what I thought. So is, for the third category that I talk about, whether it's reinsurance, is a better plan reinsurance at the state level or high risk pools? Because they both kind of end up doing the similar thing.
Right. They're different flavors of each other. I think that has worked really well. If a lot of what we did during the Trump administration is we had our state empowerment waivers, and a lot of the states that exercise those waivers are not Medicaid waivers, but they actually developed reinsurance pools, and across the board they saw premiums go down. So actually, during the Trump administration, premiums in the individual market started to go down year over year. So we were actually seeing that decrease because of a lot of regulatory changes that we made.
Okay. I think everybody's brain is full.
Yeah. Lots of problems in healthcare, and the important point, there's no silver bullet, right? But,
well, an honest discussion about this stuff involves quite a bit of complexity, and I get really frustrated with all the demagoguing that generally occurs with the healthcare debate. What are you doing now? Are you enjoying a little bit of time off?
I am working with some private equity firms that are obviously interested in healthcare, and I'm on a few boards. So, it's nice to kind of work on that private side and see, how companies are trying to be more innovative and deliver healthcare better. And a lot of the value-based principles that you're talking about, that's exactly, the companies that I'm working with, they're trying to promote those concepts, through primary care, through insurance. So, it's a different, it's almost like the issues are the same, but you're just wearing a different hat. You're on a different side of the fence. So yeah, I'm enjoying it. I don't know what comes next. People sort of say, what are you going to do next? I'm like, I'm just dealing with what's in front of me.
Yeah, that's a good call. Well, Seema, thank you so much for the very informative discussion. I think everybody's smarter for it. Appreciate you being on.
Great to see you. Thank you for all your help and your leadership. I appreciate it. Thank you.
I appreciate you.